Hello, I'm Greta Lenz,
And this is Catherine Pallas.
and today we're going to talk to you about cerebral palsy. As an overview, we're going to discuss our case report, different causes of cerebral palsy, different types, the pathophysiology of the types of cerebral palsy, different clinical features, treatment and management of cerebral palsy, and anesthesia implications. Our case study is up first. So, the article is entitled Assessing the Neuroprotective Benefits for Babies of Antenatal Magnesium Sulfate, an Individual Participant Data Meta-Analysis. This research was part of an initiative called AMICABLE, which stands for Antenatal Magnesium Sulfate Individual Participant Data International Collaboration, assessing the benefits for babies using the best level of evidence. As we will discuss, cerebral palsy is a developmental disorder that results from brain injury to the motor cortex during fetal development or birth. It's the leading cause of disability in young children, and therefore much research has been done to find areas and cures and preventative measures. This research group analyzed the effects of magnesium sulfate when given to women at risk of preterm birth on clinical outcomes, including fetal death and development of cerebral palsy. Magnesium's neuroprotective benefits are still a little unclear at this time, but we do know that it can block glutamate receptors, which may prevent post-hypoxic brain injury in the perinatal period. Overall, the research article performed a meta-analysis of 5 randomized trials with 5,493 parturients, 6,131 babies, in studies that included women at risk for preterm birth, who were randomized to either be given magnesium sulfate as a treatment or randomized to a control placebo group, and then subsequent outcomes for the baby were included. Overall, the study found that the magnesium sulfate administered does provide neuroprotection to prevent cerebral palsy and reduce their overall risk by 32%. Magnesium sulfate also reduced the risk of fetal and infant death. There were no adverse outcomes for either the mother or the baby, no negative effect on APGAR scores at 5 minutes, and the number needed to treat to benefit was 46 babies. The statistical data was reported with a 95% confidence interval that did not include parity. Additionally, benefit was seen regardless of the cause of preterm birth and across gestational ages, and there was a minimal variation in outcomes related to the amount of time prior to birth that the magnesium was administered or the dose given. Ultimately, the recommendation from the study is to administer magnesium sulfate close to the expected preterm birth. For example, if a parturient presents to the mother-baby unit with an imminent preterm birth, and to administer the smallest effective dose of 4 grams intravenously with or without 1 gram per hour maintenance dose, as both methods were found to be beneficial. Overall, magnesium sulfate is inexpensive and has shown to be neuroprotective and may reduce the risk of cerebral palsy in babies born prematurely.
Cerebral palsy is one of the most crippling disorders of childhood. There are about 500,000 children in the United States alone that have this disorder. Cerebral palsy is an umbrella term that describes a group of non-progressive but often changing motor impairment syndromes caused by lesions in the brain. It is caused by damage to the motor cortex. The motor cortex is responsible for coordinated movement. Characteristics of cerebral palsy include abnormal development of the immature brain before, during, or after birth for up to 1 year of age. It is a disorder of movement, muscle tone, or posture. Intellectual disability and seizures are also common in this disorder. Infants born prematurely will be delayed and should be assessed in terms of their conceptual age. Infants with cerebral palsy or sensory deficits, such as auditory and visual, may have normal mental development, but the handicap may interfere with assessment of mental status. Several causes of cerebral palsy are known, which can affect the fetus, which include impaired embryo implantation, chromosomal abnormalities, anoxia, trauma, infection, radiation, and maternal toxemia. In this picture on the right, you can see additional risk factors for developing cerebral palsy, which include premature birth and low birth weight, a long, difficult labor, which goes with the picture below it of medical malpractice, serious illness and infection, genetic abnormalities, and exposure to certain medications or substances during fetal development. Genetic and teratogenic influences on the development of cerebral palsy are multifactorial and not yet fully understood. Maternal diabetes and maternal nutritional deficiencies can also produce neurologic damage in the fetus. As the case study showed, the use of magnesium sulfate in the preterm newborn and also head cooling during or after resuscitation at birth may reduce brain damage and risk of cerebral palsy. There are certain imitators that seem like the patient may have cerebral palsy. Within the last couple of decades, a large percentage of children were identified as having cerebral palsy for unknown reasons. Why is this? Imaging and testing methods have improved, allowing other identifiable causes of a child's neurologic condition. A small percentage of these children may actually have a treatable and slowly progressive condition. Therefore, every attempt to find an underlying cause for a child's suggested cerebral palsy should be made. For example, there is a glucose transporter deficiency that causes a child to have ataxic movements and seizures that mimic cerebral palsy. The American Academy of Neurology recommends the evaluation of a child with cerebral palsy of an unknown cause, as it may actually be a slowly progressive encephalopathy. Cerebral palsy has various types. I'm going to discuss the pathophysiology of these different types of cerebral palsy. Brain damage may affect the pyramidal system, causing spasticity, or the extrapyramidal system, leading to dyskinetic, ataxic, or hypotonic cerebral palsy. Cerebral palsy is divided into three broad categories, which includes spastic, dyskinetic, and ataxic. A child may have symptoms of each of the cerebral palsy types, which leads to a mixed variety disorders which make up about 13%. Pyramidal or spastic cerebral palsy results from damage or deficits in the brain's corticospinal pathways, which is the upper motor neuron, in either one or both hemispheres. It is associated with increased muscle tone, prolonged primitive reflexes, exaggerated deep tendon reflexes, rigidity of the extremities, scoliosis, and contractures. Cognitive impairment occurs in about 30% of children. Children with spastic cerebral palsy commonly present for orthopedic procedures because of contractures at major peripheral joints. Extrapyramidal, non-spastic cerebral palsy is caused by damage to cells in the basal ganglia, thalamus, or cerebellum, and includes two subtypes, which include dyskinetic and ataxic. Dyskinetic or athetoid cerebral palsy is associated with extreme difficulty in fine motor coordination and purposeful movements. Their movements are jerky, uncontrolled, and abrupt, resulting from injury to the basal ganglia or thalamus. Ataxic cerebral palsy is associated with damage to the cerebellum and manifests as gait disturbances and instability. The infant with this form of cerebral palsy may have hypotonia at birth, but develop stiffness of the trunk muscles later in infancy. This lack of flexibility exaggerates the infant's inability to balance body position without support.
So regarding regions affected, depending on the severity of damage and the specific region of the motor cortex involved, there will be different regions affected. Most cerebral palsy cases have at least some amount of paralysis, and the severity is very individualized and varies from one person to the next. The regions are classified as monoplegia, affecting just one limb or body part, hemiplegia, affecting all of the limbs on either the left or right side of the body, diplegia, affecting two body parts, usually both legs, and quadriplegia, that affects the entire body, including the neck and trunk. The more regions affected, the more severe the symptoms and side effects, like pneumonia, and also other conditions like blindness and epilepsy. The hemiparetic cerebral palsy can occur after a stroke to the middle cerebral artery, before or at the time of birth. Also, it's important for us to note that functional improvement after surgery in children with spastic diplegia and hemiplegia is better than those who suffer from spastic quadriplegia. Clinical features of cerebral palsy include cognitive impairment, mental retardation, lack of muscle control, including difficulty swallowing, excessive salivation, hypotonia, dystonia, abnormal reflexes that are underdeveloped, and difficulty maintaining posture and balance. They also have poor fine motor skills. They may have vision and hearing loss, epileptic seizures, difficulty communicating due to their poor oral motor function. They may have behavioral disturbances and also systemic disorders that affect GI systems, respiratory, urinary tract, and bone and joint mobility. Furthermore, GI dysmotility may be exacerbated after scoliosis surgery and may cause persistent vomiting and bloating. Pancreatitis can occur in up to 30% of cerebral palsy patients postoperatively, and it's more common in patients with gastric reflux and reactive airway disease. Not all children with cerebral palsy have all of these symptoms, and each case is very different from the next, so it's important to perform a thorough health history for cerebral palsy patients. For cerebral palsy treatment, it's aimed at mitigating symptoms. There's currently no cure for cerebral palsy, but with symptom management and therapy, their quality of life can be improved. Some common treatments performed include orthopedic surgery to improve performance and ease of movement, gait analysis that increases the age of the patient at the first orthopedic surgical procedure. Cerebral palsy patients often undergo speech therapy, musical therapy, physical therapy, and occupational therapy to improve fine motor skills. They do recreational therapy and even hippotherapy with animals. The medical modalities include IM botulinum toxin type A, which helps to delay and reduce frequency of surgical procedures on the lower extremities. And intrathecal baclofen has been studied and helps relax the skeletal muscles by its action on GABA receptors, and it has shown to reduce spasticity. Surgical interventions vary amongst their indications and timing during the patient's life. Some other common procedures include dorsal rhizotomy, which is a neurosurgical procedure that selectively destroys problematic nerve roots in the spinal cord. And then bone and soft tissue surgical procedures help lengthen or even weaken those muscles that are tight and spastic to give the opposing muscles a chance to have muscle balance. All of these treatments have the ultimate goal of reducing symptoms and helping those with cerebral palsy live independent and productive lives as adults. As far as anesthetic implications regarding intellect, it's important for us to know that children with cerebral palsy often have previous experiences of operating rooms. They will possibly have had multiple surgeries, and it's possible for them to have some post-traumatic stress and high anxiety levels because of that. They may have communication disorders and sensory deficits that make the entire process of going in for a surgical procedure extremely anxiety-provoking. Also remember that just because they may have difficulty with fine motor control and speaking doesn't necessarily mean that their intelligence level is affected. Always explain what you're about to do and include them in decision making. If they do have cognitive disability, have a parent or caregiver accompany them and consider pre-medication for induction of anesthesia. Also, an important note is that because of multiple surgical procedures in the past, a history of latex allergies should always be investigated.
There are also very serious respiratory anesthesia implications for the cerebral palsy patient. Neuropathic scoliosis includes cerebral palsy and other neurologic disorders. When looking at a patient's chart, if you notice that they have cervical scoliosis, you should be prepared to have difficult airway equipment close by, since these patients may have difficult airways. Significant thoracic spine curvature may alter lung function, leading to a decrease in vital capacity and FEV1. Curvatures greater than 100 degrees may be associated with significant gas exchange impairment. Disorders of gas exchange impairment include atelectasis, infiltrates, hemothoraces, pneumothoraces, and pleural effusions. Thoracic curvature may also result in respiratory alterations during sleep, such as obstructive sleep apnea and hypopnea. Some anesthetic implications involving medications related to the cerebral palsy patients include succinylcholine, Succinylcholine may be used because it does not cause hyperkalemia in these children. Nonverbal children with cerebral palsy require less propofol to obtain the same BIS values than do otherwise healthy children. The MAC of halothane is about 20% less in children with cerebral palsy, whether or not they took anticonvulsant drugs. Concurrent medications used for the treatment of cerebral palsy can also influence anesthesia. Cisapride can cause prolonged QT intervals. This drug is used to help with GI issues. Sodium valproate can cause platelet dysfunction and affect drug metabolism. Anticonvulsant use increases resistance to neuromuscular drugs. Other anesthetic considerations involves the use of rapid sequence intubation. Patients with cerebral palsy may be drooling, have a decreased ability to swallow secretions, and gastric reflux, which may dissuade some against inhalation induction, but there is no evidence that rapid sequence induction is actually safer. Intraoperative hypothermia is common in children with cerebral palsy. Thermal homeostasis should be managed aggressively from the moment the child enters the operating room. Children with cerebral palsy have disordered temperature regulation due to hypothalamic dysfunction, reduced muscle bulk, and fat deposits. Contracture deformities, spinal deformities, decubitus ulceration, and skin infection must be considered when positioning the patient for anesthesia and surgery. Poor nutritional status affects postoperative wound healing and the risk of infection. Intravenous access may be difficult. You may want to consider a smaller size needle for these patients. Blood loss of 1,300 to 2,200 milliliters is significantly greater in patients with cerebral palsy. Plaster jackets and hip spicas have also been associated with mesenteric occlusion and acute gastric dilatation. Extensive plaster casting is an important component of bone and soft tissue surgical procedures. These casts may conceal blood loss and limb swelling within the cast that may contribute to compartment syndromes. Some anesthesia implications related to pain include the fact that pain assessment is difficult in these children. Opinions of parents and caregivers are extremely valuable in the assessment of pain. The parents can help discriminate pain from other factors such as irritability on anesthetic emergence, poor positioning, a full bladder, or nausea. Selective dorsal rhizotomy is associated with severe pain, muscle spasms, and dysesthesia. Epidural and intrathecal morphine have also been used to control this pain. IV morphine and midazolam have also been successful. Pain and spasm are regular features postoperatively. Systemic benzodiazepines, baclofen, dantrolene, and clonidine have been used to reduce these muscle spasms. Oral benzodiazepine should be used with caution if combined with opioid analgesics. Epidural analgesia is particularly valuable in orthopedic procedures. Occasionally, 2 epidurals at different spinal sites may be required for multi-level surgery. In summary, we have covered a case report that was also featured and drawn about in our presentation, causes of cerebral palsy, types of cerebral palsy, and the pathophysiology related to the different types of cerebral palsy. We also discussed clinical features, treatment and management of these patients, and finally, anesthetic implications for our practice.
And these are just various phases of cerebral palsy. The lady in the top right picture is named Ms. Maysoon Zaid, who gives a TED Talk entitled, "I Got 99 Problems, Palsy's Just One." And she's really upbeat and positive, and a prime example of how people with cerebral palsy can live a full and active life. And these are our references. We hope you enjoyed our presentation.